to all. I'm Dr. Abhijeet. I'm currently a fellow in Geriatric Oncology in the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. My topic for today is intrinsic capacity in older patients with cancer. I want to thank the organizing team and especially Dr. Vanitha ma'am and Dr. Anand sir for giving me this opportunity. So I have no conflicts of interest to disclose. So we'll be going through these topics, that is how older population is unique, the role of GA, in brief, healthy aging and intrinsic capacity, assessment of intrinsic capacity in our daily clinic, and IC in older patients with cancer. So this image shows the projected percentage of people above the age of 60 around the globe in the next 3 decades. And in India, it is said that in the past half a century, the proportion of them aged more than 60 has tripled. And it is predicted that in the next 2 decades, it will increase by around 40%. So this unique group is because of their rate of biological aging is heterogeneous across these individuals. Their health, their functional status, and their quality of life cannot merely be summarized by the sum of their diseases. And older persons are at an increased risk of developing single or multiple diseases, including malignancies. They experience a certain degree of functional as well as cognitive deterioration. They are likely to report more depressive symptoms, and their family, social, as well as financial conditions are more complex. So the comprehensive geriatric assessment as an approach to care for older persons can be considered as a milestone in the care for these people, and it helps in improving the medical outcomes and quality of life in older persons, and it requires a multidisciplinary approach. It was Warren in the late 1930s who came up with this operational idea, and he suggested that these complexities in these people could be handled better by CGA, and it can also be considered as a tool to an index of phenotypic age as opposed to the chronological age. In this graph, we see the solid black line, which represents the chronological age, which increases at a steady state. But more interestingly, we see the phenotypic change, which occur over time. And in the early part of life, this range is quite narrow, and it starts to broaden more as the age progresses above the age of 60. This is exactly why we see in our settings that people of the same age may not have their same features, and vulnerabilities would be different among them. So CGA, as defined previously by ma'am, it is a multidisciplinary, multidimensional, interdisciplinary diagnostic process which is focused to determining a frail older person's medical, psychological, and functional capabilities to develop a coordinated and integrated plan for treatment as well as long-term follow-up. So the traditional disease-oriented model is inadequate to address the needs of older population, and the recently proposed constructs of intrinsic capacity as well as physical resilience has the potential to reshape the future of care for older patients with cancer. And in contrast to the earlier construct of frailty, which is centered on the functional deficits, these constructs accentuate the positive health attributes of the people. So the frailty models, these are the two basic models. That is, on the left side, we see the phenotypic model. On the right, there is the deficit accumulation or the frailty index. In the phenotypic model by Linda Fried, they include 5 symptoms and signs, and an aggregate of them is taken, and the people are categorized either into being robust, pre-fail, or frail. And in the deficit accumulation by Rockwood et al., it is based on the hypothesis that as deficits keep accumulating with increasing in age, and an index is formed by having enumerated the number of deficits present divided by the total number of deficits which were accounted for. The benefit of measuring frailty is that the detection helps the clinician in making an informed and also modify the decisional algorithm in the treatment plan. The screening of frailty should not be considered as an endpoint, but rather as an entry point to model an adapted care for individuals at risk of negative outcomes. And identification of frailty should further lead to analysis of what is causing and or contributing to the person having increased vulnerabilities. So despite all this, we see that the among the oncologists, 74% of them referred less than 10% of the patients for a geriatric assessment. And probably, as ma'am mentioned, lack of time and lack of clinical staff are key factors which are uh, causing reduced implementation of geriatric assessment. So it was the World Health Organization which came up with this concept of healthy aging, which is defined as a process of developing and maintaining functional ability, which is required for healthy life of older adults. And it is not based merely on the presence or absence of disease, and it focuses on the functioning based approach oriented around building and maintaining the ability to do things that they value. And this functional ability is determined by the intrinsic capacity of an individual, the environment in which they live, as well as interaction between the two. So these are certain factors which help or modify health in older adults. We have the individual factors, not only like disease and genetic, but also the age-related changes and behavior, as well as environmental factors, which include assistive technologies, social facilities, as well as transport. So intrinsic capacity is defined as a composite of all the physical and mental capacities of an individual. We will see what are these domains of physical and mental capacities in the coming slides. And functional abilities, combination and interaction of this intrinsic capacity with an environment. I would like to use this example to try and explain what it exactly means. So let's consider this elderly gentleman who is having a poor vision. Now that impaired vision is his intrinsic capacity. There is no way that he himself as internally can increase that capacity. And this will limit his functional ability varyingly depending on the grade of impairment in the vision. But by using external factors in the form of, it can be assistive devices, it can be technology or any other forms, this can improve his capacity, the vision in this case, which will lead to an improvement or increasing in the functional ability of the person. So the continuum of intrinsic capacity can be seen as categorized into three broad groups. The line in red is the intrinsic capacity, the one in blue is the functional ability. The initial phase is the high and stable capacity, where the focus should be on preventing chronic conditions and also to ensure an early detection and control. And in the second stage, where there is a beginning of decline in their intrinsic capacity, we see that functional ability can still be maintained by using devices. And here the goal would be to reverse or to slow the declining in capacity. And in the third stage, we see that there is a substantial loss in capacity, in which condition it would be important to manage the advancing and chronic conditions. So the domains in intrinsic capacity include locomotor domain, the sensory domains, vitality, psychological capacity, and cognition. And these domains have further divisions. For example, in memory cognition, we have memory, intelligence, and problem solving. For locomotor, we have balance, muscle strength, and gait. In sensory, we have visual capacity and hearing capacity. In vitality, we have hormonal function, energy metabolism, cardiorespiratory function. Psychological, we have emotional vitality and mood. So how to evaluate intrinsic capacity? What I will be saying here are only how can we use it in a clinic. If I'm sitting in a clinic, how can I do it quickly, maybe within like 5 seconds, and say what are the impairments and in which domain we need to focus and try to increase the functional ability of the person. So these are derived basically from the WHO's integrated care for older people, where they have made a stepwise care plan for these patients, so that even primary care physicians can provide appropriate care for the older population. For cognitive capacity, they suggest asking a simple question. Do you have problem with memory or orientation, such as not knowing where one is or what day it is? And if the answer to this is yes, they suggest screening them by doing two things. That is, one, ask them to remember three distinct but familiar words, following which you ask them regarding the orientation to time and person and space. And following that, we ask them to recall the three words. And if they cannot answer one or two questions in the orientation, or they're unable to recall all three words, then we would say that there is an impairment or reduction in their cognitive capacity, and they probably require further evaluation. For locomotor capacity, they suggest a chair rise test, which is a simple test in which you just ask the person to sit in the middle of the chair, cross and keep their arms over their chest, rise up to full standing position, and then sit down again and repeat it 5 times. If they cannot stand up to 5 times within 14 seconds, then we consider that their locomotor capacity is impaired and they will require further evaluation as well as treatment plan. In vitality, they suggest you asking two simple questions. That is, do you have unintentionally lost 3 kilos over the last 3 months, and have you experienced a loss of appetite? And an answer as yes for either of them will be considered as positive. They do also suggest using other screening tools such as the MNA, but the issue with MNA is you would require to know the BMI of the person as well as the mid-arm circumference and calf circumference, which may take an extra time. In the sensory capacity, it includes the visual as well as hearing capacities. For vision, they suggest asking a simple question, that is, do you have any problem with your eyes, difficulties in seeing far, reading, or eye disease, or currently under medications for diabetes or hypertension? If it is yes, then they require further evaluation. And for hearing, a simple tool that can be used would be a whisper voice test, where you just stand one arm length behind the patient, ask them to close the opposite ear by pressing on the tragus, and softly whisper 4 words and ask the person to repeat. And then we can repeat the same test on the opposite ear. And if they are able to repeat more than equal to 3 words in each ear, it's considered as normal hearing capacity. For psychological capacity, they suggest asking the patient, over the past 2 weeks, have you been bothered by feeling down, depressed, or hopeless, and little interest or pleasure in doing things? If either one of them is yes, then you would say that the person has an impairment or a reduction in their psychological capacity, and they would require further evaluation. Even screening tools such as GDS as well as PHQ-9 can be used here. So I just want to share this pro forma which was made in a geriatric OPD. And if you concentrate on the red part, it includes all the screening for all the 5 domains of intrinsic capacity. And you can see that it hardly takes 1 page in the pro forma. So it is easily doable, and the time taken was found to be around 3 to 5 minutes only. Okay. So coming to intrinsic capacity in older cancer patients, though in recent times we have many studies of intrinsic capacity in community setting, older adults, and also we have a study of 1-year follow-up among patients who have been admitted, we do not currently have any study which have used the conceptualization of intrinsic capacity to in the geriatric oncology setting or in older patients with cancer. Though as individual domains, they have been tested. For example, there are studies which have shown that nutrition or timed up and go test, which is a part of the locomotor capacity, can individually predict mortality, but there are no studies which have used the composite score per se. From our clinic, from the geriatric assessment that we do, for cognition purpose, we use the MMSE. For locomotor, we use the timed up and go. For psychological, we have the generalized anxiety disorder and GDS. And for vitality, we use the MNA. And for sensory vision, we have a screening question as well as we check the visual acuity. And for hearing, we have a screening question, and we use a questionnaire called as the hearing handicap inventory in elderly. And from all these, we can calculate the intrinsic capacity of individuals. And this is an unpublished data which I'm sharing here. So we have a complete intrinsic capacity data of around 635 patients with a median age of 68 and with 75% of them being male. And we arbitrarily defined impaired intrinsic capacity as impairment in 2 or more domains. And we found that nearly 57% of our patients had an impaired intrinsic capacity, which was strongly correlated with poor function, which is activities of daily living as well as instrumental activities, and they were also more likely to be frail. We found that 13% of them had all the domains intact or normal, 30% of them had 1 domain abnormal, and 32% of them had 2 domains which were abnormal, and around 2% of them had all 5 of the domains which were abnormal. And among the individual domains, we found that vitality was the most affected with nearly 69% of them, followed by the sensory domain as well as locomotor domain. And we believe that because of our multidisciplinary team, which includes our dietitians, the psychologist, occupational and physiotherapist, and the clinical pharmacologist, we can really work on these domains and try to improve the functional ability of these patients. So the action plans which could be kept in mind when after measuring the intrinsic capacity would be to improve the musculoskeletal function, mobility, and vitality, to maintain the older adults' capacity to see and hear, to prevent the cognitive impairment and promote psychological well-being, manage age-related conditions, prevent falls, and never also support the caregivers. To summarize, a geriatric assessment is a useful tool to identify vulnerable older patients with cancer. Functional ability is a combination as well as an interaction of the intrinsic capacity of an individual with the environment. The five domains are the locomotor capacity, sensory and visual sensory capacity, vitality, cognition, and psychological capacity. And the goal should be to screen for deficits in individual domains and improve their functional abilities. Thank you.